And hello, everyone. Welcome back to class. So, this is our main screencast for week number 2. And in it, we're looking at measuring health and disease. So, here is a breakdown for this week. We've got this main screencast, which more than likely, as I get recording through it here, will break up into 2 smaller screencasts. There is a supplemental screencast which is illustrating what I'm looking for when it comes to doing your screencast presentation for this class. And there is also a short screencast which will, again, present the upcoming major assignments, your presentation, and your poster, and provide the scoring rubric for those. This week you have a homework assignment. You can find it on Canvas. Each problem will note how much that problem is worth. The overall assignment is worth 10 points. So at the end of last week, I assigned to you Barak et al. And the purpose of that article is not to become an expert in the article's topic, but rather to appreciate the study design. And so the title kind of gives it away here. It's a prevalence study. And so that's what we're looking at. We're looking at prevalence this week. And in this particular study, they're looking at the prevalence of, so they're going to be looking at some percentages, and traits associated with low bone mineral density. So if you read through the abstract, they talk to you about the types of individuals they were looking at, 93 high school aged runners, aged 13 to 18. And as you go through it, you start to see, especially as you get into the results section, some percentages. And the percentages is a common way, or using percentages is a common way of expressing data from a prevalence study. And then they do go on to talk about how they use multiple regression analysis to identify potential factors that were associated with menstrual irregularity. Another feature of this paper to highlight is the presentation of the data. And so if we look in table 1, some of the things you've learned from your other biostatistics classes, you're going to be using these types of things in your EPI papers too, looking at your mean data. Then we see with the figure, we have a presentation of the prevalence data, and we get an idea about the prevalence of certain conditions or certain status of the population in this study, and then it appears to be that they're comparing them to prevalence data of other populations to show that there is a difference. Obviously, they're not able to compare statistically to see if there's a difference in this type of study because it's different papers that they're drawing on, but they are able to visually represent that. So the purpose of this week is to gain an understanding of measures of disease or injury frequency, such as looking at prevalence and incidence. Key messages from the chapter: the measure of health and disease is fundamental to the practice of epidemiology. A variety of measures are used to characterize the overall health of populations. And population health status is not fully measured in many parts of the world, and this lack of information poses a major challenge for epidemiologists. All right, in 1948, the World Health Organization defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease. So what's the relevance of that? Well, when we're doing an epidemiologic study, we as the researcher or researchers need to define what health and disease is. In some cases, we may be looking at individuals who are free from disease or free from injury. And in some cases, we may be working with individuals who have a disease, and you're looking for recurrence. What are the odds of something happening again? So we've got to be very clear about that. Now, some definitions in epidemiologic studies can be very simple. Simple meaning the disease is absent or the disease is present. So an epidemiologist or a researcher doing an epi study would then categorize subjects based upon the presence or lack thereof of the disease. You're going to want to develop and include an operational definition for your injury or illness of interest. This will help you to categorize subjects into either a sick or injured category versus a not sick, not injured category. Here's an example of an operational definition that I used. It is one that I adopted from my dissertation chair, and it's one that you could potentially adopt because it's been utilized in the research literature. An operational definition of an injury was any muscle, joint, or bone problem / injury of the low back or lower extremities that occurred during practice or competition via a non-contact mechanism that required the athlete to be removed from that day's event or to miss a subsequent practice or competition. So it's pretty lengthy there. You could always revise it to something like this. Any injury involving the musculoskeletal system that occurred in the low back or lower extremity area or region that occurred during a sanctioned practice or competition via a non-contact mechanism that required the athlete to be removed from that day's event or to miss a subsequent practice or competition. Now, what were some strengths of that operational definition? Well, time loss. By having an injury, having a time loss component to it, either that they were removed from practice or that they missed the next sanctioned event, helps to create objectivity. There was time that was missed. Why is that of value? Well, I have seen papers where an injury was anything that was a deviation from the norm. Somebody having some soreness, getting evaluated by their team's athletic trainer, and not necessarily missing any sport, but just that interaction with the athletic trainer was counted as an injury. So why does that matter? You may make an argument, well, the athlete's needing care, we should count it. But what's the next step? After you're trying to figure out how injuries occur, what's the epidemiologic nature going on, the next step is trying to reduce the number of injuries, correct? You're trying to intervene in some capacity. Can you intervene when somebody's just having soreness? Can you intervene to help out when somebody hasn't actually missed time? So there's where coming up with objective measures are important. The other thing is comparing contact versus non-contact. In my definition, I only allowed those injury mechanisms resulting from a non-contact um, situation to be counted. People were still getting hurt via contact, but again, it gets into what can you potentially reduce the risk of? Can you reduce the risk of a non-contact injury? I would argue that you might have a greater chance of reducing the risk of a non-contact injury versus a contact-related one. Now, what's a potential weakness of my operational definition? Well, there wasn't always a specific medical diagnosis. I would have the athletic training staff collect injury information for my studies. And if somebody had a knee sprain, but they didn't have specifics like maybe the valgus stress tests were negative or the ACL tests were all negative, but somebody's still experiencing an injury to something that's non-contractile, so it's a knee sprain, well, that's not very specific. The more specific you can be, the better in the long run. As clinicians, we may lack access to certain tools that allow us to optimize our ability to rule in or rule out a definite or a diagnosis. So, what we're talking about here is trying to be as precise with your operational definition of injury as possible. What if you were wanting to work with a population that experienced patellar tendinopathy? Well, if you're doing an epidemiologic research study looking at risk factors associated with patellar tendinopathy, you would definitely want to have a diagnostic ultrasound available for you because that's going to help to find the patellar tendon abnormality in the tissue. You couldn't just rely upon palpation because is your palpation getting the patellar tendon? Or are you palpating something else in that anterior knee that is painful? So again, you want to be as specific as possible. There are several measures of disease frequency. They're based on the concepts of prevalence and incidence. So prevalence and incidence help to answer the following questions. The first one's a prevalence one. What proportion of a group of people has a condition? The next one, at what rate do new cases arise in a defined population as time passes? That is going to be an incidence. So people who are susceptible to a disease or injury, those are the individuals within our population at risk. So when you're doing a study looking at injuries in high school athletes, you're going to want to make sure that you're only recruiting high school athletes and not collegiate level athletes. Other examples, looking at your population of risk, these should all be kind of, like a no-duh. You wouldn't include females of the biologic sex as subjects in a study involving the prostate. If we flip down kind of the same thing at the bottom, you wouldn't include males in a study looking at cervical cancer. Now in the middle there, you most likely wouldn't include non-runners in a study looking at risk factors for running-related injuries. And I say most likely because there's probably situations where if you're looking at active individuals who are doing other types of sports, maybe you would include them just to see that those things specific to runners weren't causing injury in the non-runners. But more than likely, you wouldn't include non-runners in that study. There are two major classifications that we said before, prevalence and incidence. Prevalence types of studies are also known as cross-sectional studies. So a fraction or a proportion or a percentage of a group of people possessing a clinical condition or outcome at a given point in time. That's what we're talking about with prevalence. We're trying to figure out that percentage. Now there's point prevalence, which is measured at a single point in time for each person. There's also something called period prevalence. And period prevalence is kind of like an in-between between prevalence and incidence. With period prevalence, all cases that were present at any time during a specified period. And we'll go into more detail a little bit later on. An incidence study, also known as a cohort study, this is a fraction or proportion of a group of people initially free of the outcome of interest that develops the condition over a period of time. And a couple types there, the cumulative incidence and the incidence density. Measures of frequency are expressed as proportions. So in the numerator, it's the number of patients experiencing the event or the number of cases. And the denominator is the number of people in whom the event could have occurred. So in other words, your population that you are monitoring. Prevalence and incidence data becomes useful to clinicians and researchers when it is converted to rates. Again, the rate being the number of cases divided by the corresponding number of people in the population at risk. And it's expressed as 10 to the nth power, or what you'll see is 10 per 1,000 or 5 per 10,000. Point prevalence, again, that's a measure at a single point in time for each person. Here is a point prevalence example. This is all made up stuff. But what we've got here is you've got a skilled nursing facility or a skilled nursing home, and there's 200 residents. And you want to know what the point prevalence is of residents impaired by stroke June of 2014. So you've got a table here. There's 10 people presented here. You can assume that the other 190 are healthy. In this group here, you're trying to figure out what is the prevalence, the point prevalence of people that have, or I should say, that are impaired by a stroke June of 2014. So what we would want to do is go through the list here and look and see wherever there was a dot and a line continuing on, that is first diagnosis followed by impairment. C means that person's been cured with treatment, and obviously cured is debatable after a stroke, so don't think of it along those terms. This is just the example that I'm drawing from here. We can call it not impaired by stroke if that makes things any easier for you. We're looking at June, so we've got one person impaired, two people impaired. Third person here looks like they passed away, so they're not going to be part of our count. We've got a third person impaired, fourth person, fifth person impaired. We've got somebody that's not included because they were cured. We've got another person impaired, and somebody else that has passed on. So we've got 1, 2, 3, 4, 5, 6, 7. Is it out of 200? Or is our number different now? It should be different. We have 7 people impaired by stroke out of the 198 people in the facility. So doing the math, 7 divided by 198 gives us 0.0354. If we make that per 100 residents now, we move the decimal spot over 2. So that means that 3.54 per 100 residents were impaired with stroke in June of 2014. Period prevalence. So this again is that in-betweener. I'm not sure I've seen too many period prevalence studies within physical therapy or athletic training literature. Period prevalence is the proportion of a population that has the condition at some time during a given period of time. It includes people who already have the condition at the start of the period and those who acquire it during that period. For example, during a 1 year period of time, there were 20 pre existing cases of meningitis and 15 new. So at baseline, when they started the study, 20 people had meningitis, and then over a 1 year period, another 15 developed it. So 35 cases divided by 30,000 people in the population. Can continue to do the math from there, and you get that there were 11.67 cases per 10,000 people for that 1 year time period. Lifetime prevalence, total number of persons known to have had the disease for at least some part of their lives. Lifetime prevalence could be, you could say, the lifetime prevalence of low back pain is 80%. That's a number that's shared a lot, where people experience an acute episode of low back pain and it affects 80% of the people, not all 80% at one time, but it is a common experience. Okay, I'm going to pause the recording here or stop the recording. This will be part 1, and we'll continue on with part 2. So go ahead when you're ready, move on to that one.